This is Dr. Zabczynski, and this presentation is on mood disorders. There's a short but sweet video on the criteria for diagnosing mood disorders at this link. Disorders are changes in one's mood. Think of mood on a continuum from low to high. On the low end is depression, and on the high end is mania, and in the middle is a neutral mood. The mood disorders that we will cover are major depressive disorder, bipolar disorders, cyclothymic disorders, and suicide. Major depressive disorder is common in primary care settings. It's characterized by substantial negative changes in mood, thinking, and behavior. There is sadness, irritability, and apathy. Here are some statistics. In the United States, about 8.4% of adults will experience major depressive disorder in their lifetime. Females have a higher rate than males for unknown reasons. 17% of adolescents between the ages of 12 and 17 will develop symptoms of major depressive disorder. 30 to 40% of elderly with chronic medical conditions will develop major depressive disorder. 9% of women develop postpartum depression within 1 to 4 weeks after delivery, and about a half of those develop symptoms before they deliver. The economic burden is about $210 billion per year in healthcare costs and lost income. Major depressive disorder is the leading cause of disability among people aged 15 to 44. And it ranks among the top 3 workplace issues. Once a person experiences one major depressive episode, the possibility of another is high. There is a 40 to 60% chance of recurrence. How do you know a patient's depressed? Some patients report depression, but there are some tools we can use. The Patient Health Questionnaire 9 or the PHQ-9 is an excellent tool for primary care. It's a checklist of 9 symptoms. Depression scales can be filled out in the patient waiting area, and they're helpful in determining the presence of symptoms and also in tracking progress of treatment. Here's a clinical pearl. All patients who present with depression need to be screened for bipolar disorder. Why? Patients rarely present to their provider complaining of mania or elation. They come in complaining of depression. We don't see the mania and we have to ask about it. I've included a sample of each of the assessment scales or questionnaires, and while you may not wish to go over them at this time, you can download them or put them on your phone or iPad to use in your clinical setting. Talk to your preceptor if they use questionnaires and ask which ones they have on hand. I've had several colleagues who have instituted quality improvement projects for their DNP that involved implementing a patient questionnaire to improve identification and treatment of depression. The symptoms of depressed mood can be remembered through the mnemonic SIG-E-CAPS: sleep changes, interest lost or anhedonia, guilt, worthlessness, energy, lack, concentration reduced, appetite change, psychomotor change. The next 2 slides are examples of questionnaires that primary care providers can use in the clinic setting. This is the PHQ-9. The next slide is the quick inventory of depressive symptomology. These are some of the geriatric considerations. In addition to depressive mood and anhedonia, they may have excessive feelings of guilt. They may also exhibit vegetative symptoms along with cognitive and somatic symptoms. And sometimes they just don't know what to do with themselves. The geriatric depression scale is helpful. These elderly patients often have co-occurring medical conditions and they take lots of medications. The Beers criteria can assist in selecting drugs that may be appropriate for them. Geriatric depression scale is very helpful. Each yes gets 1 point, and points greater than or equal to 10 almost always indicate depression. For pediatrics and adolescents, the classic symptoms of depression include irritability, fatigue, insomnia, and sleeping more, and decline in academic performance. The Pediatric Symptom Checklist, or the PSC-17, is helpful. The Natal Depression Scale should be part of every postpartum visit. In primary care, you may see a new mother for a number of reasons after discharge from the OBGYN. Have a high index of suspicion for postpartum depression and ask about it. Many women suffer needlessly thinking it's the blues, but the blues don't last more than a few days. Depression can be a feature of many psychiatric disorders. High comorbidity with anxiety disorders, alcohol use, eating disorders, and schizophrenia. Differentials need to include bipolar disorder and do some screening, underlying medical conditions such as thyroid disease, adrenal dysfunction. Thyroid and adrenal can mimic depression. Medications that cause depressive symptoms include cardiac drugs, antihypertensives, antiepileptics, antiparkinsonian, analgesics such as NSAIDs, antibacterials, steroids, and cancer drugs. Over-the-counter drugs and herbal agents and alcohol can also cause depression. Neurological disorders that cause depression include Parkinson's disease, Alzheimer's disease, cerebrovascular disease, and cardiovascular disease. A major depressive disorder can be distinguished from dementia with regard to onset. A person with major depressive disorder may develop what we call pseudo-dementia, which develops very suddenly. In a person with true dementia, that dementia develops over time. For postpartum depression, on your differential, you can put postpartum blues. But postpartum depression lasts longer and the symptoms are much worse and include feelings of worthlessness. There are some labs you can order. Urinalysis, you can do a drug screen, do some routine blood work, look at the CBC and electrolytes, check thyroid and adrenal function, and in women of childbearing age, do get a pregnancy test before you start prescribing. The DSM-5-TR symptom criteria require 5 or more symptoms on that list of SIGI caps, and they must have depressed mood or anhedonia. The symptoms must last for at least 2 weeks, the same 2-week period. The goal for managing major depressive disorder is remission, which is the virtual absence of depressive symptoms, or a PHQ-9 score less than 5. A response is a substantial reduction of symptoms, or at least a 50% decrease in the PHQ-9 score. So you can see the value of doing a PHQ-9 after instituting treatment. Relapse can lengthen the time to remission and can also predispose the person to future relapses. Treatment for mild to moderate depression can be either medication or psychotherapy. If the person has severe depression, then the guidelines recommend simultaneous use of both therapy and medication. We have to assess for suicidal intent or plan. Anyone with an intent to hurt themselves or others needs to be sent to the ER for admission. The clinical guidelines for depression recommend the second-generation antidepressants. The duration of the medication treatment for uncomplicated MDD is a minimum of 6 to 12 months. It's important to note that about less than 1/2 of patients experience complete remission with an initial course of antidepressant therapy within 4 to 6 weeks. Incomplete relief that comes from stopping the treatment early or not increasing the dose to an effective level can lead to relapse. Remember that everyone responds to treatment differently. Genetics plays a big role in the response to medication, and these medications affect neurotransmitters such as serotonin, dopamine, and norepinephrine. Follow-up must be done during the treatment to ensure adherence to the regimen, response to the drugs and psychotherapy, and their safety. We have to assess for suicide risk at every visit. The suicide risk increases as a person recovers their energy. Follow up with the PHQ-9 or the other depression scales. Therapeutic dosing takes time and attention. Contact a person every 2 weeks within the first month, every 1 to 2 weeks within the first month of therapy, and then every 4 to 8 weeks thereafter. Patients may begin to feel better in about 2 to 3 weeks, and they may have satisfactory relief within 4 to 6 weeks, but that's not the typical. Patients with 1 or more years of untreated depression may need a good bit longer treatment with drugs and with therapy, and failure to achieve remission may result in relapse. Tricyclics were the first antidepressants, and they were discovered in the 1950s. These work by preventing the reuptake of neurotransmitters, serotonin and norepinephrine, in the brain and central nervous system. A little review of physiology of neurotransmitters in the brain and CNS. The presynaptic neuron releases a neurotransmitter which crosses the synapse to attach to a postsynaptic receptor. That's how the impulse gets transmitted. Reuptake is the process by which the synapse is cleared of neurotransmitters. This is done by the presynaptic neuron, which reabsorbs the neurotransmitter. It recycles it and reuses it. By blocking the reuptake of the neurotransmitter increases its availability to bind to the postsynaptic receptors. So there's more neurotransmitter hanging around longer, and the postsynaptic receptors can take in more, and that seems to improve mood. Each generation of antidepressants was developed to target specific neurotransmitters and decrease side effects. Same with antipsychotics. So with antidepressants, we have first generation, which are the tricyclic antidepressants or TCAs. The second generation are selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors. Also, the 5-HT2 receptor antagonists and norepinephrine dopamine reuptake inhibitors. These are all second generation. Some caution about antidepressants. Not all medications are approved for children. All medications have a black box warning for suicidal behavior risk in children and adolescents. Geriatric patients, the primary care provider needs to consult the Beers criteria for potentially inappropriate medication for all medications before prescribing to a geriatric patient. There are many drugs that geriatrics take, and there can be a lot of drug-to-drug interactions. All antidepressants can cause serotonin syndrome if they are combined with other serotonergic drugs. An example is an SSRI with a triptan or a migraine medicine. Serotonin syndrome can be mild or it can be deadly. Symptoms of serotonin syndrome are the 3 A's: altered mental state, abnormalities of neuromuscular system, and autonomic hyperactivity. SSRIs work by blocking the reuptake of serotonin and increasing the serotonin at the postsynaptic neuron. This improves symptoms. The response rate to SSRIs is 60 to 70%, while the remission rates are about 20 to 35%. Overall, they are the safest class of antidepressants in terms of overdose risk. You can remember the SSRIs by this mnemonic: effective for compulsions, panic, and sadness. And I think this is helpful through all of these various mental health lectures. E is for escitalopram, Lexapro. F for fluoxetine, Prozac, and fluvoxamine, Luvox. C for citalopram, Celexa. P for paroxetine, Paxil, and S for sertraline, Zoloft. SSRIs are FDA approved for children. You can remember these by little elves: E for escitalopram, F for fluoxetine and fluvoxamine, and S for sertraline. For breastfeeding moms, sertraline and paroxetine are almost always undetectable in milk. Side effects of SSRIs include agitation, dizziness, headache, drowsiness, insomnia, nausea, vomiting, and xerostomia, or dry eyes. These symptoms can be mitigated by changing the time of day that they're taken, or over a period of time they do lessen. Other side effects include sexual dysfunction, weight gain with all except paroxetine. There is an increased risk for suicidal ideation in children, adolescents, and young adults. There's a black box warning. For dosing, with the elders, we want to start low and go slow. Remember that the blood-brain barrier is less in elders, and so that they may get more of the effect with a lower dose. Titrating is important for other people, that we increase the dosage every few weeks until symptoms resolve. There are some warnings. We need to avoid sudden discontinuation. SSRIs have a short half-life, and withdrawal syndrome, flu-like syndrome for SSRIs is real. And so we can avoid that by weaning them off SSRIs over a period of weeks. I've already talked about serotonin syndrome. A couple of things to avoid, especially St. John's wort, and no grapefruit products. If a person is taking an MAOI inhibitor, then they need to be off that for 14 days before starting an SSRI. Keep in mind that the therapeutic effect of an SSRI can take up to 4 weeks, sometimes longer. The SNRIs, or selective norepinephrine reuptake inhibitors, work by blocking the reuptake of serotonin and norepinephrine in the brain and CNS, and this increases the circulating serotonin. The response rate for these is 60 to 70%, and remission rates can be up to 50%. Same things with dosing, titrating, and length of therapy. Also, warnings to avoid sudden discontinuation. We want to avoid prescribing with MAOIs because of serotonin syndrome. Side effects of the SNRIs include agitation, weakness, dizziness, headache, drowsiness, insomnia, nausea, vomiting, and xerostomia. Again, there is an increased risk of suicidal behavior in children, adolescents, and young adults. People that have bipolar disorder can experience a mania taking an SNRI. SNRIs are contraindicated in closed-angle glaucoma because they do have an anticholinergic side effect. They also can cause sexual dysfunction. You can remember the SNRIs through this mnemonic: depressed and vexed, where D is duloxetine and desvenlafaxine, and V is venlafaxine. Tricyclic antidepressants were the first antidepressants, and they work by blocking the reuptake of neurotransmitters, serotonin and epinephrine. Most of these end in line or amine except doxepin. These have been used to treat depression and nerve pain from diabetic nephropathy or fibromyalgia and insomnia. Response rate is 43 to 70%, and remission rates are between 25 and 60%. They can take up to 4 weeks to achieve the desired effect. Warnings: there is high lethality with overdose because of cardiac arrhythmias. Side effects are anticholinergic with blurred vision, vision light sensitivity, urinary retention, dry mouth and constipation, or you can use the mnemonic: can't see, can't pee, can't spit, can't whatever. Orthostatic hypotension is very common, and this is a fall risk in elderly people. So we do not use these TCAs in patients with a history of seizures, glaucoma, or urinary retention. There is a black box warning here: increased risk of suicidal behavior in children, adolescents, and young adults. There is a risk of arrhythmias, risk of cardiotoxicity, QT prolongation, and you have to monitor EKGs and blood pressure in these folks that take TCAs. Example of the Beers criteria, looking at TCAs, you can see that they should be avoided in the geriatric population and why. The Beers criteria can actually be downloaded onto your phone for use in your clinical area, and there is a printable PDF in the Moodle shell for you. There are other forms of depression besides major depressive disorder. Persistent depressive disorder, what was once called dysthymia, is chronic depression. It differs from MDD based on the DSM-5-TR criteria for SIGI caps and the length of time. It differs from adjustment disorders. Symptoms of depression and anxiety that occur within 3 months of a stressor in life, that's situational depression, and typically resolve within 6 months. Persistent depression waxes and wanes, but it never really goes away. They can describe themselves as kind of sad, and I think of Eeyore. This type of depression can last for 2 years. Bipolar disorder is a mood disorder with 2 states: depressive episodes and manic or hypomanic episodes. Bipolar disorders are defined by the presence of mania or hypomania rather than by depression, which is common to both types. Bipolar means moving between 2 poles of affect or mood and behavior, from elation or mania to hypomania to depression and back. Think of it as a roller coaster. Between mania and hypomania. Well, the DSM-5 describes mania as a period of abnormally and persistent elevated, expansive, and irritable mood, and abnormally and persistently increased activity, lasting for 1 week and present for most of the day, every day. Mania that is not attributable to substances or a medical condition. Mania that causes significant impairment with daily function, such as interfering with work, family, or socialization. Mania is diagnosed when 3 of the following symptoms, 4 if the mood is irritable instead of elevated, are present for at least 1 week and present most of the day, nearly every day. You can use this mnemonic to remember the symptoms of mania. Dig fast, where D is distractibility. They're highly distractible and unable to concentrate. I, irresponsible, irritable, and impulsive. They do not think of consequences. They go on spending sprees, go gambling, drive fast. They're hypersexual. G, grandiose, inflated self-esteem. I can do anything. F is flight of ideas. They move from one stream of thinking to another without stopping. They'll wear you out. Activity increase. Increased motor, psychomotor agitation, or goal-directed activity. They may start many projects and not finish any of them. Sleep decrease. They may need only 2 to 3 hours of sleep, and then they're full of energy again. T is talkative. This is pressured speech. You cannot get a word in edgewise. They keep talking. Hypomania is 3 or more of dig fast for at least 4 days with no significant impairment to daily functioning. Remember, the whole thing about disorders is disorders mean disorderly life, that life cannot be lived as it has been. So when someone is in a manic period, it interferes with their daily living. Somebody that's hypomanic, they may have symptoms, but they can still function from day to day. The feature of bipolar 1 is mania. The diagnosis requires the presence of 1 or more manic episodes lasting at least 1 week, most of or nearly every day, that cause significant impairment in different facets of life. Manic episodes with 3 or 4 of the symptoms of mania, dig fast. Major depressive episodes are not required for bipolar 1 diagnosis. Hypomanic episodes commonly occur. A patient who develops mania while taking an antidepressant, they have a diagnosis of bipolar 1. Bipolar 2 is characterized by at least 1 episode of mania and at least 1 major depressive episode. Cyclothymic disorder is alternating between hypomania and depression that does not meet the criteria for bipolar 1 or 2, and it lasts for 2 years. This is an example of the mood disorder questionnaire that can be used in the primary care setting. All patients with depression need to be asked about a history or family history of mania or hypomania. Why? Someone in a manic episode feels invincible. They're not going to go to their PCP, the F and P. They may not have the insight into mania. Sometimes a family member is needed to tell the provider about the manic episodes. Get a family history for depression and bipolar disorder. There's a 10-fold risk increase for bipolar disorder when a first-degree relative has a diagnosis of bipolar disorder. Administer the mood disorder questionnaire and include family or significant other or caretaker in screening. Again, patients do not always have insight into their behaviors when they're manic. Early onset or younger than 25 years is a clue for bipolarity. It doesn't tend to occur after middle age. Adverse or inadequate antidepressant response, hypomania, agitation, erratic response may point to bipolar versus major depressive disorder. Remember, if they have mania or hypomania, they probably have a bipolar problem. Differentials include stroke, brain tumor, MS, hyperthyroidism, traumatic brain injury, medication reaction, vascular dementia, delirium, substance use disorder, and major depressive disorder. Disorders are managed with mood-stabilizing drugs, atypical or second-generation antipsychotics, antidepressants, and talk therapy such as CBT. The goals are complete remission of current symptoms, mood stabilization. Think about the neutral position on the scale. Prevention of future mania and depression, and returning to function before the onset of symptoms. Bipolar disorders are managed with mood stabilizers. And a way to remember the mood stabilizers, or that you need a mood stabilizer, is the mnemonic: when your mood is labile, you need a mood stabilizer. So labile is like back and forth or up and down like a roller coaster. For the mood stabilizers, use the mnemonic CLOVER, where C is for carbamazepine, L for lamotrigine or lithium, O for oxcarbazepine, and V for valproic acid. The same slide in the schizophrenia PowerPoint. Atypical antipsychotics or second-generation antipsychotics can be used to manage acute mania. There is a risk for extrapyramidal side effects and metabolic syndrome with the second-generation antipsychotics. Antipsychotics are commonly used to manage schizophrenia, bipolar disorder, mania, and autism. You, as the PCP, the family nurse practitioner, will be aware that these drugs cause weight gain, increased lipids, and increased fasting glucose. In other words, patients can develop metabolic syndrome. We have to monitor weight, sugar, lipids, and their waist circumference. In geriatrics, use these second generations or atypical antipsychotics cautiously. They're appropriate for treating psychosis and severe agitation. However, again, the blood-brain barrier is thinner in older patients. You can start low and titrate slowly and use the lowest effective dose. See the Beers criteria. Particular concern with second-generation atypical antipsychotics are for sedation, orthostatic hypotension, and falls. Suicide is the 9th leading cause of death in the United States. It's the 2nd leading cause of death among adolescents aged 10 to 14 and young adults aged 25 to 34. Risk factors include divorced, separated, single, widowed, older adults, veterans, the LGBTQ+ population, Native Americans, Caucasian males. Term suicidal ideation, that's thinking about it. Sometimes a person can be chronically beset with suicidal ideation for years. Parasuicidal behavior means non-lethal self-injury. Suicidal thoughts often accompany major depressive disorder and bipolar disorder. About half of all suicide victims saw their primary care provider in the month before their suicide. You can use the ASSESS or ASQ. It takes 20 seconds, and there's an example here. The other thing is a mnemonic you can use for suicide, and it's called SAD personas, where S is for the sex, A is age, D is depression, P is previous attempt, E is ethanol, alcohol use, R is rational thinking, S, social support loss, O, organized plan, N, no spouse, A, availability of lethal means, S is sickness. So when you're talking about this with people, you have to be very specific. Do you have any thoughts of hurting yourself? What is your plan? And if they can give you a detailed plan, it's time to call for assistance. Primary care providers is to recognize the warning signs. We can use internal coping strategies, relaxation, physical activity, to get them, to distract them, keep them engaged. And we can contact people who can help. Contact professionals or the hotline or the ER, and restrict access to lethal means. That includes guns, pills, poisons. 88 is the Suicide and Crisis Lifeline. This is a national network of local crisis centers that are available 24 hours a day, 7 days a week. So just like 911 is for emergencies, 988 is for Suicide and Crisis Lifeline.